Hello and welcome. And my name is Joe Ceramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. Thank you for joining today's Grand Rounds presentation. A couple of things to go through before talking about today's presenter. First, throughout the presentation, feel free to write in questions or comments into the chat or the Q&A section. I'll collect those and I can go through those at the end with today's presenter. There's a group of us that work on Grand Rounds each week, including Samhara Braha as a coordinator in communications and Mike Walker on technology. We do record and then archive the presentations on the Grand Rounds website. I want to acknowledge funding for the series from the Ripley Fund and the Garvey Institute for Brain Health Solutions. And towards the end of the presentation, I'll put a brief evaluation into the chat box. It's only a couple of questions long. I encourage you to complete that. That's helpful with planning Grand Rounds and in communicating with presenters and speakers afterwards. Now, for today, today's presenter is Dr. Claudia Reardon. Dr. Reardon is a professor in the Department of Psychiatry at the University of Wisconsin. And Dr. Reardon has had a sustained interest and focus in mental health in athletes and sports psychiatry really since residency, and has developed expertise in this area. Dr. Reardon works clinically as a staff psychiatrist and consulting sports psychiatrist for the University of Wisconsin Collegiate Athletics. And of course, consultant in this case applies to direct clinical care of athletes, but Dr. Reardon has also served as a consultant more broadly, including for the US Open tennis championships, for the National Football League, the International Olympic Committee, including being the lead author of a report that came out of that International Olympic Committee. Now, Dr. Reardon has also maintained sustained focus on advocacy in professional societies such as the American Psychiatric Association, the International Society for Sports Psychiatry, and more recently as a psychiatry delegate to the American Medical Association House of Delegates. Finally, I'll say Dr. Reardon also teaches widely on the topic of sports psychiatry, including within the University of Wisconsin psychiatry residency, where that specific curriculum, the sports psychiatry curriculum, won a national award from ADPERT as a model curriculum for psychiatry residents. So we're very fortunate today to hear from Dr. Reardon, and I'll stop there and turn it over to Dr. Reardon. Thank you.
Well, thank you so much for that kind introduction. I really appreciate it. So happy to be here, hailing from the other UW, and happy to be talking about this topic that's so near and dear to my heart, mental health in athletes. And I see many familiar names on the participant list, which is wonderful. Dr. Herring, Dr. LaPlante, and others. It's really, really great to be here. So for the next 45 minutes or so, I'll just be starting with some background information and then jumping into the common mental health symptoms and disorders and talking about how they affect athletes, how they manifest, really focusing more on the symptom presentation, how that's nuanced within the world of sport, and not so much the treatment management side of things, with a few exceptions. And the specifics will cover a range everywhere from sleep concerns to substance use and gambling disorders and everything in between. By the end of this talk, hopefully you'll be able to incorporate an understanding of the biopsychosocial stressors that contribute to mental health symptoms and disorders in athletes into your formulations and treatment plans, identify those nuanced presentations of these conditions in athletes, and then really appreciate the culture of sport and use that to establish rapport when working with athletes who are suffering from mental health symptoms and disorders. And I hope all of you will find some kernels of helpfulness in this talk, whether that's working with recreational exercisers all the way up to elite athletes, or coaching a youth sports team, or merely being a spectator or a fan of sport. So where am I drawing my information from? Well, in the way of background, the International Olympic Committee, going back decades now, has held a series of consensus meetings on a variety of sports medicine related topics. And these are meetings really designed to come up with consensus statements representing a summary of the world's literature and recommendations and future research directions. And going back decades, these have covered things like asthma in athletes, nutrition in athletes, various injuries such as concussion. But I would attest that there was a glaring omission until quite recently, in terms of never before had the overall topic of mental health in athletes been covered. Thankfully, the IOC saw the light, and in 2018, a few years ago now, they did convene a consensus meeting on this topic. Thankfully, our ultimate charge as that work group, the Mental Health and Elite Sport work group for the IOC, was indeed to scour the world's literature on the topic and publish this consensus summary statement based on what we found in the literature. And you can check out the June 2019 British Journal of Sports Medicine issue if you want to see our admittedly rather lengthy consensus statement summary. And accompanying that, we published as well 10, as we call them, subspecialty papers that really dove into the details of very specific mental health conditions in athletes, things like a separate manuscript on PTSD in athletes, gambling disorder in athletes, etc. So all of those are in that June 2019 issue. And much of the information I'm going to share here today is drawn from this work group because, as I said, we did really thoroughly comb the world's literature. The IOC generally references elite athletes. By elite, what we mean is collegiate, professional, or Olympic. Much of what I'm going to share today, though, does include athletes across the entire spectrum. And as well, since this was published now a couple of years ago, I've added in newer references too. So the central premises, I think, are important to share. The central premises both of the IOC work and of everything I'm going to share and what I truly believe, and that is that mental health is not apart from, but rather a part of athlete health. Health is health, and of course, that includes the brain. To promote mental health is to enhance performance. And if you want to get coaches' attention, this is what I found you need to really emphasize, that your athletes are not going to be performing to the best of their ability if they have untreated anxiety, depression, eating disorders, etc. And all of us have a role to play, whether it's the treating clinician or the fan, in creating and maintaining a health-promoting environment that supports mental health. Thankfully, this is a topic that has gotten increasing attention recently, because I would argue that sport has historically kind of been one of the final frontiers in terms of where some of the worst stigma has existed. It's that culture of toughness. It's the fear of loss of sponsorship opportunities, loss of scholarship dollars, if athletes are going to be speaking up about this. And with the courageous words of several high-profile athletes, as you see pictured here, I think that has really gone far in starting to break down the stigma. And I can tell you, when someone like Naomi Osaka or Simone Biles speaks up in the media about these issues, I see the impact the next day in my office, as in there are more athletes coming in and feeling like it's okay to do that. So that really, I think, has started to make a difference. And when the athletes do come in, what are the kinds of things that I'm seeing that the literature says are problems for athletes? And this is really a composite of what I see every day in my office, what I saw earlier today. Things like tremendous pressure to perform, time demand, such that athletes talk about they always feel like they're shortchanging everything. There's not possibly enough time in the day to feel like they can make their coach happy, that they can do academically what they need to do, that they're preparing for their career beyond sport, and that they're giving time and attention to friends and family members. Every day, I hear athletes talk about feeling like a commodity. They absolutely receive differential amounts of attention based on how well they're performing in sport. And that absolutely leads them to feel like my worth as a person therefore equates with my sport performance. Certainly that's in the form of attention from coaches. Athletes talk about If I'm performing well, my coach responds to my texts and phone calls that much quicker versus if I'm injured or not doing well. And it really extends to the media and quite honestly, friends and family too, for better or worse. Athletes talk about this sense of pressure to continue in their sport, even when they don't want to, even when, quite frankly, they hate their sport at that point. And there's this sense of an obligation to their family who, they're not stupid. They know how much time, money, energy, and resources has been poured into the idea that they'd be successful in their sport. In collegiate athletes, the reality that if they quit sport and no longer have a scholarship, they may not have any financial way to stay at the university or in college in general. And this is such a common thing mentioned to me too. It's the only thing people ask about when I go back home, whether that's the collegiate athlete on winter break or whatever it is. And the football player then says, how could my answer possibly become, I quit the football team, when asked, how's football going? When that's been such a big part of their identity. Discord with coach and teammates. And the reality is, for a lot of our athletes, there's no time to have social contacts other than people who are on your team and your coaches. And so if you're not getting along with these people, that's a big social problem. And they talk about what they expected, what teammates and coaches were made them to feel like they could expect when they were recruited to that university or that team. It doesn't match the reality. And the fact is, they're essentially always in competition with their friends for starting positions, scholarship dollars, etc. So it's a really difficult dynamic. Injury and surgery, which I think we woefully underestimate. So many athletes count multiple surgeries, laid up with injuries for significant amounts of time in physical pain, and that's a really big deal. And then finally, post-retirement adjustment. So the fact is that so many of our athletes at the high school, collegiate, and beyond level, this has been the significant part of their life and their identity for countless years, as long as they can remember. We could talk all day about the increasing early professionalization and subspecialization in sport. I mean, starting at like really, really young ages. And so if that means you really haven't developed other parts of your identity, and that's often the case, what does that mean then when you retire and try to figure out now who am I? So with all that small sampling of the stressors that exist in the world of sport, what are the kinds of ways that the symptoms and disorders show up? So let's talk about sleep first, common things being common, and starting with insufficient sleep, simply not getting enough sleep. Data from the NCAA show this is a big problem. In season, men's sports, 5.8 hours per night. Women's sports, in volleyball, down to 6 hours per night during season. And why is this a problem? Well, we care about the health and well-being of our athletes. We want them well rested. And what about this question? What's the strongest predictor of injuries in high school athletes? This is somewhat of a landmark study at this point. Is it number of sports played? These are all things that have been looked at and hypothesized as possibly the answer to this question. No, it's not that. Is it grade in school? Time spent participating in sports, when you add up school and private club teams, and so many kids are doing both of those all year long. Nope, it's not that. Participation in strength training, which perhaps is protective against injury if you're strong enough. Use of a personal coach for training outside of school, maybe that's a marker of overdoing it. Subjective assessment of enjoyment in sports. Maybe you're less likely to get injured if you actually enjoy your sport. That's a marker for a less injury risk. No, it's sleep hours, the strongest predictor of injuries in high school athletes. Sleep hours, and specifically athletes averaging less than 8 hours per night, 1.7 times more likely to have had an injury versus those getting more than that. The mechanisms could include things like impaired psychomotor function if you're sleep deprived, dampened reaction time, decreased cognitive function, decreased mood, whatever it is, you're way more likely to get injured. Circadian dysregulation, second of of the sleep problems that we're going to talk about, defined as misalignment between the individual's sleep-wake pattern and the desired pattern, as shown here by our crew team at this UW out on the water at 5 a.m. This is a common problem, and that timing of sport training is one of the big reasons. So if my crew athletes, and I see many of them, have to be up at 4 because they have to be out on the water at 5 a.m., do the math backwards and figure out what time these 18 to 23-year-olds have to go to bed in order to get enough sleep. Well, their brains simply are not wired to go to bed early enough to make that possible. And even if they could, they're surrounded by people who don't have to be up at 4 and to bed by 7 or 8. And that just logistically makes it impossible. And then finally, the frequent travel across time zones. I mean, and this extends down to quite young ages. And sometimes it's every week, multiple times a week even, which really makes the idea of sleep hygiene in a lot of ways very, very difficult, maintaining those consistent sleep times, wake times, etc. And then finally, insomnia. And the reasons for this are many in athletes, as you can imagine as well. So things like pre-competition anxiety, sleep being viewed as a flexible commodity, and then that ends up contributing to poor sleep hygiene. We talked about all of the things that athletes are trying to balance. When it comes down to the fact that something has to give, there's simply not enough time in the day to do everything I need to do. Understandably, it feels to the athlete like sleep is the thing that will have to give. And so some of that is the reality. Some of that is, I think we are not educating athletes in the real importance of sleep. And I think if we said to all of our athletes, you know, what do you think is one thing you could do to improve your sports performance by 20%? And that's what the statistics show. The answer is sleep. Well, I think if that were realized and appreciated, that might be prioritized a bit more. FOMO. So those of us working with young adults, adolescents, surely hear that acronym multiple times in our offices every single day, fear of missing out. So you have to have your phone by your bedside, because what if you miss the text from coach or teammates? You know, the sense that you have to be constantly monitoring your social media profiles, and there's reality there too in terms of sponsorships and these kinds of things. And that's just not conducive to being able to ease into sleep, surely. Activating video games, light from those screens, caffeine, which is used heavily by athletes, muscle soreness and pain makes sleep hard. It really does. And then the inconsistent schedules with practice times, competition times, the red-eye flights that they're taking back from competitions, all of which make that really, really hard. So that was a world tour of sleep in athletes. Let's move on to depression in athletes, and epidemiologically, what do we know? Well, Paul Gorczynski, a psychologist in the UK, did really a very big landmark study on this topic and asked the question, how prevalent is depression in high-level athletes compared to the general population? And people were surprised by this. They shouldn't have been, but they were. And that is, it's just as common as in the general population, up to 26% in collegiate and other elite athletes, and some even greater. So those populations at even greater risk, female athletes, twice as likely as males, close to mirroring what we see in the general population. College freshman athletes at greater risk than upper class athletes by a lot. That is no surprise to me when I see that major transition that they go through. Suddenly, you know, these two huge full-time jobs of student and athlete, you know, having moved across the country or across the world a lot of times and not knowing anyone there, different, really demanding coaching styles that they're now exposed to. And quite honestly, I can't imagine how that transition goes well for anyone ever. I just can't. If athletes are in pain or injured, if they're experiencing harassment and abuse, certainly within sport, it can be outside of sport, but that is a dire problem in the world of sport. Adverse childhood experiences, the unanticipated burden of success. It's really a much easier position to be in in a lot of ways, to be the underdog than to be, say, the NCAA champion as a freshman or whatever. I mean, there's just nowhere to go but down. It's really, as much as I would like to celebrate when I see that in a freshman athlete, I just cringe because it's just a really hard position to be in. And this really interesting, increasingly compelling thread in the literature that shows that individual sport athletes at substantially greater risk than team sport athletes when it comes to risk for depression. And you could think about why that may be, and the reasons are probably plentiful, but for example, it seems that athletes who are drawn to individual sports at baseline, they may be more likely to be perfectionistic, really highly self-critical, more compulsive. Interestingly, if you interview high-level individual sport athletes versus team sport athletes and ask them, how did you get involved in sport in the first place, back when you were a kid or whatever? And the individual sport athletes, on average, are way more likely to recall things like, my parents signed me up for the sport because they thought I was overweight and wanted me to lose weight through that. Or my parents really wanted me to get a college scholarship. Like, that was very, very important to them. Or maybe I knew that I couldn't afford college if I didn't get a scholarship. So they, got me really highly involved from an early age to make sure I could do that. Versus team sport athletes, on average, who are way more likely to say things like, I signed up for the team because I just wanted to have fun with my friends, and it was fun. So you can see how that right away sets people up for different levels of risk in individual versus team sports. And then finally, within individual sports, there does seem to be a suggestion that track and field is at the greatest risk. That does line up with what I clinically see for sure. By the way, that's a picture of my brother when he was a professional track and field runner several years ago now. So moving on from depression to anxiety. So we did a review of the topic last year. It was looking across different anxiety or anxiety-like conditions. And what we found is that, just like with depression, most anxiety disorders are affecting athletes at least as much as general populations are affected. Athletes are not spared in any way. That includes GAD, social anxiety, and panic disorder. Where the suggestion of a difference arises is in obsessive compulsive disorder, wherein athletes appear to be even more affected, which maybe makes some intuitive sense if we think of a lot of athletes as being quite particular, attentive to detail, like things a certain way, and structure and organization. Perhaps that's on a continuum or a setup for OCD kinds of things. Just like with depression, we can ask who among sporting populations are at even greater risk. And this is a topic that psychologist Dr. Rice in Australia and colleagues looked at as part of the IOC work group. And what they found is that those who are dissatisfied with their career have high degrees of anxiety. Again, female, injured, similar patterns. You're going to notice these themes. Those who are in the process of retiring. Oh, this is an interesting one. So heavy social media use, and I don't think that's necessarily different for athletes versus the general population. But if you look at athletes who use social media during competition, and some sports are conducive to that, if you think about if you're on the sideline and not playing, or in between events or whatever, but that is really associated with anxiety, including social anxiety in athletes. And maybe that's because they're on there comparing themselves to others, or reading about predictions about how they were going to do, or negative commentary in the media about them, or whatever it was. But it's a big predictor of anxiety in athletes. And then types of sports. So again, individual sports, not with a good rap here. Aesthetic sports are those with judges assessing performance. So if there's a sense that appearance matters, or you're being judged, athletes talk about that being really just kind of a helpless feeling, and like it's out of my control. Quite honestly, that picture just makes me feel nervous. And aiming and fine motor sports, and athletes talk about just getting in their head, and anxiety can take over that way. I'd be remiss if I didn't mention this because this is something that commonly pops up, and Wilson wrote a good review on the topic, and that is GI manifestations of anxiety, which of course you and I all see in non-athletes too, but it does seem to show up disproportionately in athletes. So many athletes come to me having these GI symptoms and they can't find a medical cause, these urges to defecate, diarrhea, vomiting. I see that pretty commonly in athletes during training and competition. I recently had an athlete who was hospitalized. They got so dehydrated, but no medical cause could be found. And lo and behold, you diagnose and treat their anxiety, and this gets much, much better. It seems especially prominent in endurance athletes, but I've seen it football players, soccer, I mean, really across the board. It may be a manifestation of competitive performance anxiety, and it certainly can have implications for treatment. So I do well getting these folks connected with dietitians, for example, and figuring out what foods are going to work well and settle okay in their systems. And then also implications when you're thinking about medication choice and maybe going slow with the meds that have GI side effects, or choosing some that are less likely to have those side effects. Moving on to PTSD, post-traumatic stress disorder, a topic covered by Cindy Miller-Aaron within our IOC work group. And I think there's increasing appreciation that athletes suffer from this, not uncommonly, perhaps at rates even higher than in the general population. Of course, this can be the result of all of the traumatic experiences that any of our non-athletes can suffer, but then also events within sport that are unfortunately common. Certainly the harassment and abuse that we talked about, but then injuries. And I think there's more appreciation that major catastrophic injuries can really cause, for all intents and purposes, what looks just like PTSD in athletes. And I think for non-athletes, they may look at this and say, how could an ACL tear give you PTSD? But it can, and concussion especially is what's been studied here. And you see the classic symptoms, the re-experiencing hyperarousal and avoidance. And it's interesting to read and to see clinically about how this shows up then on the playing field. And so what you see is the athletes avoiding rehab, avoiding certain playing fields or courts or whatever it is that is reminiscent of where they got the injury. And they have this paradoxically inhibited efforts that increases their risk of re-injury because they're not actually doing the motion and the mechanics that they're supposed to because they're hypervigilant and scared of it happening again. And this hypervigilance and jumpiness can lead to problems like false starts and other technical failures in sport too. And so you treat the PTSD and these things get better. So we've covered the anxiety and the anxiety-related conditions. So moving on to the thing that, I mean, talk about what I treat all day, every day. This is painful. It is just so very common and assuredly more common in athletes than the general population by a lot. Up to 45% in females, up to 1/5 in male identified athletes. The higher the level of competition, the more prevalent. And when you look at disordered eating, not just full-on overt diagnosable eating disorders, we're talking about more than 60% in collegiate athletes who identify as female. And quite honestly, when I get athletes referred to me, particularly in certain sports, but shouldn't make any assumptions, my assumption is they had at some point or currently have an eating disorder until proven otherwise. And more often than not, I'm not proven otherwise. It's really a problem. So we know, of course, eating disorders require certain types of eating disordered behavior with a certain frequency and over a certain period of time, restricting, binging, or purging generally. Disordered eating, lesser extents of those symptoms and the kinds of things you can see there too, which might not meet full criteria, but things like using saunas or sweat runs to lose weight before team weigh-ins. So I mean, this happens here all the time. Women's lightweight crew, They weigh in every Tuesday. I know that a lot of my athletes are going to be doing this on Mondays and losing 3 pounds or more every Monday. It's really a problem. We could talk about why that sport even exists with that weight class and that weight limit. And the final bullet point under disordered eating that I wanted to highlight, because I ask about this, and the answer is yes, painfully commonly, and that is when you're thinking about exercise, and you can ask the athlete that, what are you thinking about? And is the answer something like burning calories or how much I'm going to earn to be able to eat later? If that's the answer, that's a red flag. And disordered eating is generally a concern because the risk is this is going to progress to full-on eating disorders if it's not addressed. Risk factors for eating disorders in athletes who are weight-sensitive sports, for sure. I mean, we see that more commonly in those sports, but I have athletes with eating disorders in every single sport. The weight-sensitive ones are those with weight classes, like lightweight crew, for example, and certainly wrestling. Those that may be aesthetic, like gymnastics, for sure, figure skating, diving, where there's that sense of appearances matter and you're being judged. And then gravitational sports, in which there's a sense of lower body weight being advantageous from the gravitational standpoint, like running. Team weigh-in's a big risk. Injury, bottom of that list there, is a big risk too. Athletes who are injured, they're used to being so physically active. They have a sense of, I usually burn so many calories that justifies all the food I have to eat. Now I'm injured, I can't be so active anymore. And they way overcompensate or undercompensate, I should say, for that decrease in activity and basically don't eat nearly enough. And it just is a setup for eating disorders. Related to the injury aspect is retiring athletes. And of all the omissions in the world's literature, when it comes to mental health in athletes, I think this is a huge one. It's covered a little bit, but I have the privilege of being able to continue to work with athletes a lot of times, even after, even after they are done with sport. And so I see what that kind of transition looks like. And what I see is a lot of eating disorders either emerging for the first time in retirement or worsening above and beyond what it was during active sport participation. So just like with injury, athletes are afraid of, oh no, now now that I'm not so active, I'm going to gain a whole lot of weight, and that changes their eating behavior in a very pathological way. You see the same kind of thing with retirement, except that it's more of a permanent situation. It's not just the temporary injury. So there's the great fear of bodily changes and weight gain, and there's unrealistic expectations about that. So a sense that I can, should, and will maintain the same body type I had when I was exercising 45 hours a week. And then if that isn't the reality, there is this true body grieving process. And athletes get very little support to figure this out. How do they eat? How do they exercise? Do they exercise at all now that they're retired and no one's making them? The reality is that usually the athletes' healthcare teams go away when they're done with sport because they, maybe graduate college and they move on, or their healthcare was tied into their team, their professional team or whatever in some way. So that treatment team goes away and no one's keeping an eye on these things. If athletes had suffered from disordered eating while they were actively participating in sport, and here I really don't mean to make gross oversimplifications or stereotypes, but what the literature suggests is that those athletes who identify as male more quickly return to healthy eating habits versus those who identify as female, where there's an awful lot of social reinforcement of weight gain and the thinness body ideal that exists for female identified people. And if the females in sport had eating disorders during sport, it doesn't tend to go away. just because their sport ends. So I think that's something to keep in mind. This is a setup. We're setting our athletes up for longstanding suffering in this way. So moving on to ADHD, which is not well studied in athletes, unlike eating disorders, where we have a pretty good amount written, but we certainly see it. And it may actually disproportionately affect athletes compared to non-athletes. The fact is, athletes with ADHD may be drawn to sport in the first place because it feels good to be active and to burn off that hyperactive steam that they have. There's that positive reinforcement that can come with physical activity for this population. And we know, I mean, I'm not telling you anything you don't know here. 1/3 of people diagnosed with ADHD in childhood continue to meet ADHD criteria as adults. So we do see this in our athletes at all level. This is a topic that was covered in our IOC work group by Doug Han from South Korea and others. And one of the things, while I said at the outset, I'm not really going into great details in terms of treatment of these disorders, I would surely be very remiss if I didn't say something about this when it comes to ADHD, because stimulants are the one class of psychiatric medicines that are outright prohibited at a lot of the higher levels in sports. So the NCAA prohibits these. Most sports teams that are professional do. And at national and international levels of competition, the World Anti-Doping Agency prohibits these as well. And the reason is that there's some 1950s data that shows that these are performance enhancing. They seem to allow athletes to push themselves harder to a higher core body temperature without perceiving as much effort as they otherwise would if they weren't taking stimulants. So that equates to possible performance enhancement. It also equates to higher risk of heat illness if you can push yourself harder and not realize how hard you're pushing yourself. And what it means is they're prohibited. There are ways around the prohibitions, and this is important for anyone working with high-level athletes to know. At the level of the NCAA, you don't fill out any paperwork to turn over to the NCAA ahead of time, but if the athlete tests positive through NCAA-based testing for a stimulant, you have to be at the ready to turn over all the documentation that they want to see. And I've got the kinds of things listed there that you need to turn over. When it comes to professional teams and national, international competing athletes, that's where you do actually have to apply for permission ahead of time if you want an exception to be made for your athlete to be able to take a stimulant. And the paperwork is extensive. It takes a long time. And a lot of times you're asked to make revisions and provide clarifying information. And I think rightly so, given safety and performance concerns with that, but definitely be prepared to do that months in advance of the time the athlete may be competing at those levels. Beyond the regulations, I do want to just say a bit more on the side effects because they really have substantial potential of impacting athletes and safety and performance. So things like impact on appetite and sleep are really, really relevant. They're relevant for everyone, but athletes who generally have to maintain quite a high intake, something like this that decreases their appetite just a little bit can be a big deal. And then again, I said athletes are at great risk for eating disorders. So anything like this that can aid and abet an eating disorder also has the potential to be problematic. In terms of the sleep side of things, well, recall the picture of our crew athletes out on the water at 5 a.m. And oftentimes on the other end of things, they're practicing their second workout of the day or doing their homework later in the day. And so a lot of times we're needing a long period of stimulant coverage. On the other hand, some athletes do not like the stimulant in their system while they're practicing during the day or while they're competing, despite their apparently being performance enhancing. Just as many athletes tell me, no, they're definitely not for me. I hate that sense of my heart rate being higher than it otherwise would be. I feel like I can't push myself as hard as practice. just had an athlete a couple hours ago saying, it takes me so much longer to recover after practice when I have a stimulant in my system. And so they want the timing to be such that it's at a low point in their bloodstream at the time of practice. So it's really careful titrating of the timing of the stimulants as well. So from ADHD to bipolar disorder, this is a topic within the IOC group covered by psychiatrist Dr. Curry in the UK. And this is definitely a topic not all that well studied in athletes. Certainly there are prominent cases such as that of runner Susie Faber Hamilton, but we just don't know how common it is. I have a handful of athletes who have this and get a new one or two a year, but we just don't know how common it is. The fact is that both psychosis, psychotic disorders, and bipolar disorder have that peak age of onset coincident with the time of peak sporting performance. Those age ranges overlap quite precisely. So it is something that does pop up in sport. And there are sport related nuances to think about, like what substances are athletes using that may be mimicking what these things look like. And I'll talk about substances very soon here, but things like stimulants, given their performance enhancing effect, they can be abused surreptitiously by athletes. Cannabinoids, which are ever increasingly marketed to athletes for helping with pain and recovery, despite there being a general lack of evidence to support that. So these kinds of things can manifest as psychosis or mania. Final bullet point, this is such a really fascinating one to me, and that is that some evidence suggests that vigorous exercise may exacerbate mania in patients, including athletes who have bipolar disorder. And this has always made intuitive sense to me, because if you think about it, anything that treats depression, treats the one pole, such as antidepressants or sleep deprivation or ECT or light therapy, that can all cause or exacerbate mania in a patient with bipolar disorder. Well, we know that exercise is actually pretty potently antidepressant. And so intense, vigorous exercise, no surprise to me, can similarly destabilize moods in people with bipolar disorder. And by definition, so many of our athletes are doing intense, vigorous exercise. And so it's like the Energizer Bunny effect. And I have seen this. I definitely have seen this. What I do is my athletes who have bipolar disorder, I have them do these mood monitoring sheets. And on there, they keep track of how much exercise on a given day they're doing. And you look for patterns, geez, when you get above 5 hours of exercise a day, is this when mania is emerging? Or I had an athlete recently, when she started to move toward the mania pole of things, she would subconsciously add on exercise. I think it was like a fuel on the fire kind of thing, but suddenly she'd be up all night running all over campus. And I think it was aiding and further perpetuating the mania side of things. So let's talk about concussion, because this is something that gets so much airplay, media attention, that, I have to at least mention it. And one of the big questions to think about when you see headlines about, does concussion cause suicide in former NFL players, or whatever the question is when it comes to sport-related concussion and mental health symptoms, what's causing what? What is that association? Is there any causality there? And I would argue that there are several possible relationships between concussion and mental health symptoms. So it could be that the concussion has a direct physiologic cause of mental health symptoms. Are you directly affecting a certain part of the brain, the limbic system or prefrontal cortex, whatever it is that is directly physiologically causing depression or whatever mental health symptom you're talking about? Is it that stressors associated with concussion or any major injury, illness, or event of course, can cause mental health symptoms, no different than any other injury like a torn ACL or the death of a loved one. It's a life stressor. Those cause mental health symptoms. Maybe it's that pre-existing mental health symptoms like depression or anxiety increased the likelihood that you get concussed. So it looks like, you got concussion, you're more likely to be depressed or anxious, but you actually were depressed or anxious at baseline. And it's the depression or anxiety on the playing field that made you more distracted or caused the muscle tension that made you more likely to get the kind of hit that led to concussion, because you were distracted, you didn't see it coming, you didn't brace yourself as you otherwise would, etc. Or finally, maybe there's no relationship at all, whether that's causal or associative. And I don't have the definite answer. It's not like it's one of these four for sure all the time. I suspect that in different situations, these are more or less relevant, but it's probably a permutation of multiple of these in a lot of cases. For sure, what we do know is that changes in mood, emotions, and behavior are common after concussion, which I would attest is a neuropsychiatric syndrome. This is for us to know about and treat. This is a psychiatric thing. Look at the screenshot of the SCAT-5. They are this screening tool that you use to assess for concussive symptoms and then monitor the process of improvement after a concussion. I feel like I'm reading the DSM criteria for GAD or MDD when I look at these, like more emotional, irritable, sadness, nervous or anxious, trouble falling asleep, feeling like in a fog. This is a neuropsychiatric syndrome. The American Medical Society for Sports Medicine published a position statement on concussion in sport in the BJSM a few years ago now, and I find this framework so helpful in terms of when I have my athletes coming to me for concussion, like the one I saw an hour and a half ago after her teammate just dropped a 35-pound weight on her head in the weight room, and thinking about, okay, what are the symptoms we're seeing and how do I categorize these? And then importantly, what does that mean for treatment of the different symptoms that you're seeing, the anxiety, mood symptoms, the headaches, including migraines, ocular symptoms, vestibular symptoms, fatigue, and cognitive symptoms. And so it helps you not forget to address all of these and not forget to ask about all of these too. Dr. Rice, I mentioned him earlier, out of Australia, did what I think is about the best systematic review on this question of concussion and specifically depression in high-level athletes. And he looked at 103 studies, merely one judged as excellent in terms of rigor and bias, but he did include 27. And what they found is that there were depression symptoms in 20% of collegiate athletes after concussion, all tested within 41 days of the concussion. So I think it's important to ask, who are those 20% who become depressed and end up in my office or your office? That's the leftmost column here. It's those athletes who had depression before they got concussed, who had migraine before they got concussed, had a family history of mental health disorders. Their brain was wired to go there, to a mental health place, high life stressors at the time of concussion. And interestingly, if not only their practice and competition was restricted, but they were restricted from team social activities and team meetings, which I think a lot of us would argue is inappropriate restriction and just further contributes to mental health problems. We can also ask what's in the rightmost column here, which is who are the athletes with concussion who don't get better in the time frame you'd otherwise expect them to, because most do recover from sport concussion within a month. And the reason I highlight this is because the answer to the question, who doesn't get better, is all about mental health. So this is us again, and that is those who get depressed after concussion, less likely to get better. Those who had depression or anxiety before getting concussed, less likely to get better within that month. Plus minus, research is kind of all over in terms of, does pre-existing ADHD delay recovery? And then if they use alcohol or other substances during that post-concussion timeframe, takes longer to get better, probably no surprise. Speaking of alcohol and other substances, we'll talk about that. And I'm nearing the end of my slides here, a topic covered by Dave McDuff at Maryland and others in our IOC work group. And what I can say is that athletes and non-athletes use similar substances most commonly. With athletes, alcohol, cannabis, nicotine, and prescribed opioids and stimulants are the most commonly used substances, though to athletes' credit, and the good news is at rates lower than non-athletes. But, and there's a big but, there are problem areas for sure, and that is that use and misuse rates are higher for athletes when it comes to binge alcohol. Athletes use overall amounts of alcohol less, and they binge way more often. Oral tobacco, like chew, non-prescription opioids, anabolic steroids, all of these higher in athletes than non-athletes, and that's across the board, more commonly showing up in power and collision sports. If I ask you what sport, time and time again, shows up as disproportionately suffering from really, really high rates of misuse, it's ice hockey. Talk about why that might be and hypothesize, and I don't know exactly why, but lots of hypotheses about it. And we know that post-competition, off-season, and retirement are high-risk times. Can be a lot of consoling losses and celebrating wins that are high-risk times too. Vaping, a big problem among young adults, starting in middle school. The misconceptions abound about these things in the world of sport, and athletes think they're harmless. They won't get hooked. They're fun flavors and no bad breath. It's a winning combination. And the reality is it does really affect you in sport. Decreased lung capacity. Athletes are leaving practice for nicotine breaks because these things have a lot of nicotine and they cause addiction quickly. I have found time and time again that if you do not ask specifically about vaping, you're just asking about, do you smoke? Do you use nicotine? No. Do you vape? Do you use a Juul or whatever? Oh yeah, every day, a lot. You have to ask about it specifically. And then gambling, another addictive disorder covered by the world's leading foremost expert on gambling in athletes, Jeff Derevensky in Canada. This is the hidden addiction. People don't ask about it, and it abounds in the world of sport. Up to 4% of collegiate athletes engage in gambling, and to the tune of actually having problems, despite the NCAA saying it's not allowed. In order to maintain the integrity of sport, athletes who might have insider information and who could throw a game if they wanted to can't do this. And yet 4% have a problem doing it. And among professional athletes where those prohibitions don't necessarily exist, the numbers are through the roof, really, really high in terms of how often it's done, and almost 10% with a gambling problem. So in conclusion, athletes are at risk for a variety of mental health symptoms and disorders, the same things non-athletes are at risk for, but these things present in nuanced ways within athletes compared to the general population. And I would argue mental health is an integral dimension of athlete well-being and performance and should not be separated from other aspects of physical health. Thank you very much.
Well, thank you, Dr. Reardon. What a comprehensive overview of sports psychiatry at many levels, considering multiple domains of assessment, disorders, nuances in clinical presentation, unique stressors, very informative. Several questions have come in, and I think we've got a few minutes, and I'd like to get to one. I wonder, Dr. Reardon, you commented on early childhood, adolescent sport experience. I recognize this might be maybe its own unique discipline or fellowship training, but could you comment on the developmental contributions and maybe risks of sport in that age group?
Yeah, well, so I mean, sport has the potential to be very, very positive for our kids. It's associated with higher rates of academic accomplishment, for team sports for kids, it's associated with lower depression and anxiety, but there are also big problems. And I think they're starting at ever increasingly young ages, parents are pressured to get their kids very, very involved in sport. You need your personal coaches and personal trainers in addition to school participation. And there's this sense of you and your kids will be irrevocably missing out if you don't do that. You ask parents of little kids, what percentage of you think your kid is going to get a college sports scholarship? And most say, yes, mine is. And the reality is, 1% are. And so that leads to a lot of pressure. Kids who have unidimensional identities because they're doing this sport year round, and that doesn't leave enough time for friends, family, sleep, etc. They're more likely to be injured and burnt out. It's really hard to extract yourself from sport. So I think it's going in a bad direction. And I think that all of that leads to parenting practices, understandably, but in coaching practices too, that are really focused on you have to be better than all of the opponents, not sort of the goal-oriented kind of coaching and parenting, which is reinforcing and praising accomplishment at being able to meet certain individual goals, not related to being better than everyone else. So sport can be healthy and it can be a setup for psychopathology.
Thank you for that response. A question from someone interested in pursuing sports psychiatry. Dr. Riddle, how does one get into this? Does one need to know as early as medical school beforehand? Where does one train? How do you get into this?
You can decide anytime you want. It's just a wonderful field to be practicing in. And I would point you toward the International Society for Sports Psychiatry. You can Google that organization. There's a curriculum on there that we, the education committee of that group, authored, which is freely available. And it's very comprehensive. If you are a member of that organization, you can complete that curriculum and then be awarded a certificate of additional training in sports psychiatry, which would denote to any future employees or teams or whatever you might want to work with that, in fact, you have received extra training in this field. The International Olympic Committee also has a diploma program on mental health in elite sport, which is not free, but it's very comprehensive, and especially if you're interested in working with very high-level athletes.
Thank you. And we've got a minute or two, and another perhaps complicated question about concussions and media coverage, social media, and concussions. Clearly concerning issues, problems that could come up from concussion. Is there a risk about catastrophizing related to that? Do you see that?
Yes, there is. Yeah. I mean, so that athletes are seeing all this media attention and the suggestion that concussion is associated with severe consequent psychopathology, at the extreme suicide. And the power of suggestion is real for sure. And I don't think, look at papers by Iverson and others, I don't think there's any compelling evidence that concussion causes suicide. I laid out those possible relationships between psychopathology and concussion, but I think concussion is associated with a whole set of biopsychosocial conditions and stressors. And it's the whole picture that is associated with mental health problems. But I think there is a risk in overemphasizing. If you get a concussion, your brain is injured in this one problematic way that is definitely going to lead to bad outcomes, no matter what else is going on in your life, because I'm not so sure that that's true.
Complicated, especially thinking about multiple, in some ways, developmental stages of an athlete moving through sport and competition, and considering a retirement. It's very interesting to consider this. And overall, Dr. Reardon, thank you for this excellent presentation on this topic, bringing up our clinical skills here, as many of us see and evaluate athletes. And I want to thank you again for joining us for Grand Rounds.
Thank you. It was my pleasure to be here. I was very happy to do this.
Well, very good. We'll end there for today. Take care.